presentation today. How many of you guys have had a COPD patient or a history in the hospital? So it's a pretty relevant thing in healthcare today. COPD can be defined as airflow obstruction, and this damages the bronchioles and the alveoli. COPD has two different branches, and in some definitions they include asthma as well. Chronic bronchitis, and you guys talked about that in your last PowerPoint. It's a productive cough for 3 months, diagnosed 3 different times in the last 2 years. And then emphysema can be described as an enlargement of the air sacs and damage to the bronchioles. And only 10% of patients with COPD have pure emphysema. Usually most patients have a combination of both. Some major causes of COPD is most patients with COPD are smokers. That is a huge reason that they inflame their airways. And then you guys also talked about secondhand smoke, so being exposed to an area with smoke, pollution. You guys also talked about that in your oncology unit. Patients who live near factories or high areas of dirty air end up with cancer. Well, the same thing happens with COPD. And then also the alpha-1 antitrypsin deficiency is a genetic risk factor for COPD. So the AAT protects normal lung tissue. When there's a deficiency, the lung is not as easily protected. We just talked about all of this. COPD is the 3rd lead causing death in the US, and it's the 12th leading cause of disability in the US. So most COPDers have poor nutrition, problems with their ADLs. You will usually see end-stage COPDers barely can walk, need a higher level of care. 35 million US adults have chronic lung disease, and this costs our healthcare system about $32.1 billion a year. Like I said before, most patients present with a combination of chronic bronchitis and emphysema. So signs and symptoms: cough, worsening shortness of breath, more mucus production. A lot of times if they're having problems clearing their airway, that ends up needing intubation. A lot of people complain of chest tightness, wheezing as well. We talked about this before, the path of 3 months of cough. Also the number of cilia decreases and the mucus and the bronchial walls become thickened, making it harder for the air to move through the passages. A lot of exacerbations of COPD occur in the winter. Drier air, the SpO2 goes down and the CO2 goes up. And then we just talked about the wheezing. When you listen to a COPDer, you can they sound very roncorous, like that. So you'll definitely be able to notice it. I actually had a patient a couple of weeks ago who was end-stage COPD, so he tripoded. So when he slept at night, he couldn't sleep lying down. And you probably will experience this in your career when you go to boost a patient up in bed and they'll panic and say, I can't lay down, I can't lay down. A lot of that has to do with their COPD. Cigarette smoking, like we said, is the most common cause. Breathing in fumes and dust, so different occupations. Painters, the different fumes from that have a lot of problems with COPD. And diagnosis. How do you guys think that you would diagnose COPDers?
Like a nursing, ineffective breathing pattern, if they have ABGs,
Good. ABGs.
Impaired gas exchange.
COPDers usually get routine chest x-rays as well, CT scans, so just being aware of all of that. Emphysema, the patho behind that is impaired gas exchange. That's from the destruction of the walls of the alveoli. This usually occurs over many years, and they're destroyed. There is surgical interventions that can be done, but they they do come at a high risk to patients. So, as the disease progresses, CO2 elimination is limited, so patients end up in respiratory acidosis. So that's why ABGs come into a big play here, seeing daily. Sometimes you do more, and depending on where you guys work, usually the respiratory therapists I work at Samaritan now do the ABGs, but I used to work at Strong, and the nurses would actually do the ABGs. So, depending on where you guys choose to go, will depend on what you guys get to do. So it's important to obtain like a complete history from patients. Like I said, the ABGs, the PFTs, pulmonary function tests, also play a big role in diagnosing. I believe these are all in the back of their packets, just talking about the different systems. Barrel chest is a big one. Barrel chest, pursed lip breathing, wheezing. Most of these patients are on home O2 care. And they definitely are a big candidate for social work, because a lot of times COPDers come into the hospital because they're not taking their care of themselves at home. So I'll let you guys look over these. And this is a chart just describing the effects of tobacco smoke. So you guys pretty much know this. Smoking decreases your sense of taste or sense of smell, and then as you damage the cilia and the bronchioles, you increase your secretions and your coughing. The Global Initiative for Chronic Obstructive Lung Disease is an initiative to help work with healthcare professionals to help raise awareness of COPD. It's a project initiated by the National Heart and Lung and Blood Institute and the World Health Organization. And their role is basically to educate people on the risk factors and how to manage their COPD. They have guidelines for diagnosing. This is determined by the degree of airflow limitation using spirometry. So respiratory therapists play a big role in care with patients with COPD. So working closely with them and diagnosing them and making sure that proper treatment is being executed. Because even though the respiratory therapists, I know a lot of them, do they do their, what was I gonna say? Do they have the respiratory therapists do like all their MDIs and albuterol treatments?
Not all of them, some
Okay.
of them. Any nebulizer has to be done by
them.
the respiratory therapist.
Okay.
And certain types of inhalers need to be done by respiratory therapy.
Okay.
But just an albuterol inhaler would be
Okay.
us.
And actually, depending on where you go, like I know at my job before I came to Samaritan, we actually did all the nebulizer treatments, and the respiratory therapists were mainly in charge of the vents. So just making sure you work closely with them, because technically they are your patients and you need to make sure that they're receiving the treatment that they need to. So a lot of times we've had to call respiratory therapists, hey, this guy needs a neb, can you come and get this? Or did you give this neb that was due at? Just follow up is really important for them. And this is more of the guidelines, and these are all in your book as well. And we just went over the pathos. And the staging. So another big thing to consider with patients with COPD is rehab treatments. So if they're not able to take care of themselves at home, this is a good option for them, and it helps them to promote their activities of daily living. It does routine around the clock O2 therapy, so that they are getting the things that they need, and then nutrient therapy. So a lot of these patients aren't getting the nutrients that they need because they're working harder to breathe. So rehab is a good possibility for a lot of these patients. Some complications of COPD, cor pulmonale, is failure of the right side of the heart. So patients with high blood pressure that continually happens makes the right side of the heart pump more. And as this continues on for a longer period of time, it puts a strain on the heart. Any chronic lung condition usually causes prolonged low O2 levels. This can also be caused not only by COPD, but cystic fibrosis and sleep apnea. So making sure these patients have their CPAP on at night and their BiPAP. A lot of patients, I don't like to wear it at night. Well, that's why your CO2 levels are higher. So as a nurse, you play a big role in education. I believe this one is in the back of your packets as well. And this is just the PAFA that we're just going over. So the vasoconstriction occurs, the heart works harder to pump, and it results in right-sided heart failure. So with the COPD exacerbations, that can progress to acute respiratory failure. And then depression and anxiety is also a complication. Why do you think depression and anxiety would have to do with COPD?
Because they're scared that they're not allowed to breathe.
Yeah, exactly. And if somebody's depressed and they're not taking care of themselves, that can be another reason for a COPD exacerbation. We discussed this before, so chest x-rays, PFTs, ABGs. Does anyone know what the 6-minute walk test is?
They walk with the pulse ox.
Yeah. That is one of them. The 6-minute walk test is actually a test that measures the distance a patient can walk on a flat surface in 6 minutes. And they usually do one before and after interventions to see how they do. So treatment-wise, it's seeing if the treatment is improving their ADLs and their sense of living. It can also help determine if the patient needs more care outside of what they're giving themselves at home. Collaborative care. So smoking cessation is obviously a huge thing in nursing education. If patients have COPD exacerbation and or COPD and they're smoking a pack a day, obviously their COPD is not going to be getting any better. So educating them on different things that can help them quit. I know there's multiple different medications out on the market. Samaritan actually has like a whole smoking cessation like teaching packet, and the respiratory therapist will go through and discuss all of those with the patients. I like to just sit in and listen so that I can reiterate to the patient because it's important. Because a lot of patients, the patient I had a couple weeks ago actually signed himself out, he has COPD exacerbation, signed himself out AMA because he wanted to go home and smoke, and smoked himself right back into intubation. So that's a big thing. Drug therapy, which we're going to talk about later, albuterols, NAD treatments, MDIs. There is surgery. There's lung transplant options. There's also a couple of other options that we'll talk about later. Usually most patients die before they get a lung transplant because they're so very few and far between, and the resources. So just thinking of that, when patients get oxygen therapy, what is one thing you guys may see in the room? Yeah, because getting oxygen is very dry, dries out their nostrils. So just different things like that to make them more comfortable is important. Obviously, no smoking while a patient is on O2. Have you ever had a patient that's come in because their oxygen tank has blown up? Yeah. So the singed nose hairs is a big thing of it. Also, COPDers can develop a tolerance for high high carbon dioxide levels. So you want to start O2 at a low rate because concern that high levels of oxygen diminishes their drive to breathe. So you don't want to give them a lot of oxygen because then it doesn't make them, their body kind of triggers that they're not working for it. So kind of, there's like a happy medium, making them work for it but not too hard. So, in absorption atelectasis, when the increase of concentration of oxygen is given, nitrogen is washed out of the alveoli and replaced with oxygen, so that can lead to a alveoli collapse. So just making sure that, again, starting O2 at low rates is important. So the different surgical therapies for COPD, there's a lung volume reduction surgery. So they remove damaged lung tissue, which improves lung function by allowing the rest of the lung to repair. Surgery on average produces a 10% improvement on expiratory volume rates. It's important also to teach patients breathing retraining, so pursed lip breathing, prolonged exhalation prevents bronchial collapse and air trapping. It's kind of something you have to like teach them and make them think about because they kind of think it's kind of funny at first. And then diaphragmatic breathing, so working on focusing on breathing through your diaphragm instead of the hyperventilating, using the muscles of your accessory instead of your chest, and that helps to slow the respiratory rate. And like we said, nutritional therapy, as these patients work harder and harder to breathe, the need for nutrition increases, and high calories, high protein diets are important. What is this? Do you guys know? Have you done this on your patient? No. Cupping to help loosen the secretions they have to help bring them up. They call it percussion, actually, percussing. But do you guys know what this is? Okay, that's good. And what does this do?
It helps loosen their secretion with vibration.
Yep. And these are just some subjective and objective things you would get from a patient, so medical history, what kind of meds they're on, what kind of lifestyle they have at home, and then you work your way down through their systems to see what it's affecting. What are some nursing diagnoses with patient with COPD besides these? Yeah, good.
Anxiety.
Yeah.
Ineffective breathing pattern. Where?
So making sure you address all these is important, and that's where education again plays a big role. These are the goals that you want to essentially provide your patient is overall an improved quality of life. So knowing how to treat their disease process and symptoms, how to recognize when they're having an exacerbation is important too. We just talked about that. Sleep, sexual activity, psychosocial considerations. Do they have support at home? Are they depressed? Do they need outside resources? And these are all found in your Lewis book as well. Now we're going to talk about asthma. This is another branch of COPD. It's chronic inflammatory disease of the airways caused by bronchospasm and mucosal edema. It's usually largely reversible spontaneously or with treatment. Allergies are the most common factors that cause it. So you see in the spring a lot of pollen, dust, mold, pet dander, things like that. Also, sometimes heat and cold can trigger it, as well as exercise. I don't know if any of you guys have asthma. A lot of kids you'll see, I remember when I played sports, just exercising sometimes sends them into a trigger. Most common symptoms are cough, dyspnea, wheezing, and a chest tightness. And it is genetics. Genetics does play a big role in that. So obtaining a full family history is important. And then also just talking about status, asthmaticus is severe and a continuous reaction that definitely needs to be addressed. And most likely, if they can't get it under control, intubation is required. So we just talked about that. Stress also plays a big role. We just talked about that. Like I said, ABG is a big diagnosing factor. So when patients get more tired, the CO2 increases, so making sure that they have the oxygen therapy that they need to function. There's different classifications of asthma. There's intermittent, mild persistent, moderate persistent, and severe persistent. This is used to diagnose and determine the initial treatment. Lung function measures are also taken, and the risk of future exacerbations will require oral corticosteroids. The patients may move to different asthma classifications over the course of their diseases. A lot of times you'll see kids and they'll actually sometimes improve their asthma as they get older, others not so much, but. We just talked about that, air pollutants, occupational factors, where you work plays a big role. If you're outside all day, that obviously can cause triggers for an asthma attack. Foods, different kinds of drugs, so it's important to make sure you are checking your patient's allergens when they come in, because you don't want to add something else to their hospital stay. Let me just talk about that. It's right along the same lines of COPD, pulmonary and emphysema, pulmonary function test, chest x-rays, measure of their O2 stats. A lot of people go through allergy skin testing to find out what their triggers are. And then also the elevated serum eosinophil count and the elevated serum IgE levels are highly suggestive of atopy, which may be a risk factor for asthma, and that can be a genetic predisposition to develop an allergic reaction. So these are just some things that we can look out for as nurses, trying to avoid or eliminate triggers, teaching different drug therapies and making sure that they are following up like with their inhalers at home or their nebulizer treatments when they feel like they're having a flare-up. SaO2 monitoring, AGs, corticosteroids. And this is the part that we just went over. This diagram does a good job just showing kind of like the patho behind it, how the IgE receptors on mast cells, then they're activated to release histamine and other inflammatory mediators. And then you can see in this diagram the tightening of the walls in the swollen mucosa. And this chart is just the different steps of what treatment may be. So you guys can take a further look at that. What are some problems you guys have seen with your meter dose inhalers? I know they're listed here, but patients trying to do inhalers. Seen when they like push it down, if they're like breathing before they even push it down. Yeah. And a lot of times this is a big educational thing, even with kids too, teaching them. So the spacer, I like to use the spacers because it gives them a little more time. They can push it down and it kind of holds it in there. A lot of older people don't have the strength to push them down, so making sure that they have the resources that they need, or maybe they need something else. Not opening your mouth wide enough. Not shaking the MDI before if it calls for that. Inhaling more than one puff, so instead of doing one big breath, they're doing like multiple breaths. And this just goes over the different inhalers and things that you need to do, like the meter dose inhalers. Most of them you shake well before using, where the dry powder inhalers you don't. I have not seen a lot of the dry powder inhalers. I don't know how, usually I don't think I've actually ever used a dry powder inhaler, but it depends on the facility you go to. A lot of the meter dose inhalers will be so many uses, so I don't know if you guys have seen them, you can like click them and it'll tell you how many are left before they're out. Just some different drugs, the guanfacine, you can actually buy that right over the counter. And the ephedrine you can too, right?
Ephedrine you can't buy over the counter anymore.
And then this is just a like screening tool that we use in the hospitals. It's similar to one. And this like tells us how well the patient is managing their asthma. And you want to do this every time the patient comes into the hospital or goes to their doctor's office to make sure that they are following up on treatments or that they have the right prescriptions for themselves. What are some nursing diagnoses for patients with asthma?
Activity intolerance.
Yep.
A lot of the same as COPD.
Yeah, a lot of it's all relatively linked. Health promotion's important, especially with younger kids, when they get the diagnosis, sometimes it can be an adjustment for them, so, just making sure that they realize, like, they're not weird or anything like that, and making sure that, they're comfortable, and making sure that family members and others are, educated in case they do have an exacerbation or anything like that. Home care for older people, is important as well. We just talked about this, increased sputum, change of loss in consciousness, level of consciousness, this is a big one, if this is happening, there's a problem, and if they aren't already in the hospital, they should be, getting there right away. Making sure that you are noticing changes like this in your patients is important. The other day I had a patient got a report, they said he was alert and oriented all day. You get there and you barely wake him up. That's a problem, he ended up being intubated later on in the evening. So, making sure that if you guys ever work nights, a lot of doctors aren't on, depending on the facility you go to, like the head doctors, it's usually the hospitals, they're covering a lot of patients. So making sure that they're aware of the changes in your patient, because, sometimes you have to prompt, maybe we should do an ABG on this guy, maybe we should come see this guy. So, you're your patient's advocate, so making sure that they get what they need is important. And a lot of the primary cause of this is a bronchial infection, and this can be due to air pollution. So management of exacerbations include, identifying the cause if possible, so if you know they're allergic to something and they've been around it, identifying that. Bronchodilator therapy is important, steroids, antibiotics, O2 therapy, CPAP and BiPAP if it needs to go to that level, and intubation. It is difficult to wean a patient from the ventilator once they've reached that point, so there's very few cases that I've seen that patients have ever come off of that after that. So, what's something to consider with patients if they're getting steroids? What patient population?
The diabetes.
Diabetics, yep, so the steroids, increase their sugars, so just making sure that you're continually checking them is important. We just talked about, bronchodilators, so there is short-acting and long-acting and oral agents that they can take. And they are the most effective for, treating bronchospasm. And we talked about the spacers before, holding the chamber, enhances the disposition of the medication into the lung. Short acting's usually over 4 to 6 hours, and that's like your albuterol, and your inhaled nebs and orals. Medium acting's 6 to 9 hours, and that's like your Zeropenex, Penex. And then the long acting's over 12 hours, and that's like your Serevent. What should you look for with patients who are on, albuterol treatments and things like that?
They can have jittering, shakiness.
What else with their vital signs would you see? Yeah. So, just making sure that that stays managed as well. These are some of other medications, for the amiophylline, you need to administer that separately in an IV, and you need to observe for toxicity. What are some, do you guys remember in your reading some signs of toxicity with that? Nausea, vomiting, seizures, insomnia. So what would you think that you would have like on standby for those types of patients if you saw those symptoms? Yes. So the activated charcoal, yep, and the syrup that they have. You also wanna limit your coffee and tea, and cola intake, because for patients that are pregnant, this can cross the placental barrier and cause buildup of caffeine in a newborn. And then you wanna wait any IV therapy that the patient's receiving you wanna wait 4 to 6 hours before you start giving any oral therapy. Just talk about these. Corticosteroids are inhaled and may be used in COPD, but they're more widely used in asthma. They can improve the symptoms, but they don't improve like your lung function at all. And they're not recommended long-term, because they can cause, muscle weakness, how do you say it? Myopathy?
Myopathy?
Myopathy, which leads to muscle weakness and the ability to function in advanced, respiratory failure. And here is some more medications. Like we talked about again, the antidepressant and anti-anxiety meds as well. Asthma, same thing, smoking cessation, O2 therapy, getting vaccinated, so make sure these patients are getting their flu vaccines and their pneumonia vaccines. Pneumonia is every 5 to 7 years. Now we can talk about the surgical management. So like I said, the lung transplants, are an option, but the organs are in short supply, so the patients usually just die before they even become eligible. The lung volume reduction, this is usually for stage 4 COPDers if the disease is not focused in one area and not widely spread, and it is the removal of the portion of the lung tissue, and this reduces hyperinflammation and allows for a functional tissue to re-expand in the lung. There's also a bulectomy, which is a surgical option for patients with a bullous emphysema. And they're enlarged air spaces that do not contribute to ventilation. So taking those out is another option. Why do you think that patients, we talked about this a little bit earlier, would need increased nutrition for their COPD?
Increased metabolism because they're trying to burn off.
Right, and they're working so hard to breathe, so, like we said, because of weakened respiratory system, they expended a great deal of energy, so they have an increased likelihood of malnutrition. Malnutrition can really, lead to muscle wasting, which is evident in the diaphragm. Have you guys ever noticed some of your COPDers are stick thin and their stomach is very caved in? Decreased vital capacity needed for more ventilation. They can't move very well, they can't breathe, going upstairs is hard. They actually expend 25 to 50% more energy, so. And then food taste is usually off for them. Think about like when you have a cold and you don't feel well, your mouth's dry, you don't really wanna eat anything, so they get like a loss of appetite because of that as well. We just talked about this, loss of fat stores and muscle mass, and then the altered taste, fatigue, and anxiety and depression. So many of these patients get nutrition therapy, which preserves muscle strength and immune system. These also maximize oral intake. The patient usually gets 25 to 45 more calories per kilogram depending on their weight. And they will need more protein, and that's usually 1.2 to 1.9 grams per kilogram. And then to be on the lookout for these, acute respiratory distress syndrome and acute respiratory failure, and then nutritional intake for that. Malnutrition impairs recovery, so the patients aren't gonna get any better when they can't breathe. So making sure that TPN, different things like that are initiated. A lot of the patients will be on those boosts, and they'll be ordered in their diet. Cause usually it's something quick they can drink down easier than eating a whole plate in front of them. We talked about this, the tissue destruction with the need for extra nutrients. High calorie, high protein diet is important. For the enteral nutrition, the commercial formulas like the Boost, the Ensure, they do have a higher calorie density, so just making sure that you're doing their weights every day is important. A lot of these patients, if they're having trouble breathing, aspiration's a huge issue. You don't want them pushing back everything that you've given them because then they have more mucus to bring up. And then the parenteral nutrition is high in glucose, so they try to avoid it, but if necessary, they will give it. So like we said, checking the patient's blood glucose is very important around the clock. And that's usually 1 to 2 grams of lipid per body weight kilogram, and you're gonna give that over 24 hours. And then these were just some symptoms: anorexia, anxiety, reasons people aren't eating with their COPD. So for nutritional assessment, usually to decide what patients need for nutrients, you're gonna do a physical assessment, assess what they weigh, how much weight loss they've had, sputum production, fatigue. You're gonna check their lab values. Is their sodium off? Is their chloride off? Do they have a gap? Is their CO2 elevated? And then consult with dietary. I don't know how much you guys have worked with dietary, but a lot of, if you ever go to a bigger hospital, dietary is very involved with their patients, and nursing. They will follow up, they are grilling you what the patient has eaten, you're tracking calories with them. So just working with them, they're like a huge asset, and they help you out a lot. So it's a second set of eyes for your patients as well. COPD patients, you wanna make sure that they're getting adequate protein, but not too much, in order to stimulate their respiratory drive. Again, that fine balance between, making sure that you're not giving them too much, but that they are working a little bit towards it. They like to do 1.2, 1.9 grams per kilogram again. And for COPDers, fewer carbohydrates. So, may require 25 to 45 kilocalories per kilogram. Teach patients to eat high calorie foods first, smaller meals, so more frequent meals, snacks. Eat their larger meals when they're not as tired, so usually we try to promote those patients to eat the meals earlier, their bigger meals early in the morning, so breakfast, and avoid gas producing foods, because then they get bloated and then they don't want to eat as much. For acute respiratory failure, it's similar to COPD, high calorie, high protein foods. And for enteral nutrition, they do home care as well. Like we talked about, high risk for aspiration, so making sure that you're properly administering this. A lot of these patients have J tubes in. We just talked about that. Small, frequent meals. Eat while well rested. Encourage use of easily prepared or convenience foods. So what's something like Meals on Wheels would be helpful for these patients. But a lot of times that's hard to regulate because it's like an outside company coming in. So educating them on what foods are high in calories, high in protein, and that are beneficial to them. This is pretty much consistent, as we talked about. Half of these patients are malnourished, so this prevents weaning from the ventilator and impairs recovery. A lot of patients you'll see on your vent may be getting TPN or tube feeds, just to make sure that they are getting the proper nutrition. But like a lot of the patients you see in the ICU, you have to make sure that they're not backing up because of that. Like we had a patient last week getting tube feeds and nobody checked his residual and his stomach was just filled with tube feeds, and then you could, like, when you were suctioning him, it's almost like the tube feeds were like aspirating out. So that's something you don't want to do. So, and you'll see these, I'm sure you see it in clinical practices that you do not want to carry forth as a nurse. So good diet helps to keep CO2 levels under control. And patients that are in adult respiratory failure, you need to initiate nutrition immediately for these patients. And same thing, high calorie, high protein diet. That's it. So I was gonna have you guys, do I have time for that? Do a case study in your book, it's the COPD exacerbation ones. You guys wanna split into your clinic, how many groups is there? Three? I'm gonna have you do 1 through 15,
What's the case study number?
29. So if one of you guys wanna do 1 through 5, the next 5 through 10, and the next 10 to 15, then we can go over them. I'll give you how long should I go on?
15 minutes.
15 minutes, is that okay? It's only 5 questions, so.
Turn it off now.
Hmm?
Turn it off.